special panel discussion with our specialists. And like I mentioned earlier, this is a knowledge sharing platform. We are now starting with our panel discussion where we will be connecting the dots, collaborative initiatives and policy ambitions to revamp India's health sector. May I please request all of you to welcome our speakers and panelists here on stage. Let's welcome our panel moderator, Dr. Professor Kamal K. Sethi, Chairman and Managing Director, Head of Cardiology, Delhi Heart and Lung Institute, and you have the images up on the screen as well. May I request all of you to please put your hands together and welcome Dr. Randeep Guleria ji. As we know, he is the visionary that we all look forward to learning and hearing from. So please welcome him with a round of applause. He's been kind enough to be a part of this panel discussion, and who better than him to take a lead onto it as well. So please do welcome him. May I also present to you Dr. Abhijat, Sheth, President, National Board of Examination in Medical Sciences. May I please welcome Dr. Harsh Mahajan, MD, Founder and Chairman, Mahajan Imaging C Labs. May I request all of you to please welcome Dr. D.S. Rana, Padma Shri Awardee Chairman, Sir Ganga Hospital, Dr. Kirat Solanki, Medical Practitioner and former member of Lok Sabha. May I request all of you all to please join us here on stage. We have with us Dr. Abhijat, Sheth, Dr. D.S. Rana, Dr. Harsh Mahajan, Dr. Kirat Solanki, of course, Dr. Professor Kamal K. Sethi, putting this element together, and Dr. Randeep Guleria, who's been kind enough to be a part of this very special segment. May I request Dr. Harsh Mahajan to please join us. Maybe we can kickstart the discussions, and once we have more of our doctors join in, we can take the discussions forward.
Hello. So good evening, ladies and gentlemen. My name is Kamal Sethi, and I have a great set of panelists with me. You have just been introduced to all of them, and this session is particularly important for us because all of us, besides being healthcare providers, are also responsible for improving the systems, giving better quality healthcare to our patients, interact with the government on different issues, and try to see how best we can work together to make things better. Now, it's named as connecting the dots, and I guess there are too many dots that we have to connect. We would have very much liked the chairman of National Medical Commission to be present here because a lot of questions that I had framed actually were for him. But maybe I can start with Dr. Guleria, who has a lot of experience in this field. You know, he's been the director of All India Institute of Medical Sciences and presently the chairman and chief of the critical care and respiratory disease at the Medanta Medicity. Dr. Guleria, we all know that we have a huge population which is increasing, and there is a lot of diversity in our population. We have transitioned from infectious disease to non-communicable diseases, and we have a large burden of diabetes, heart disease, cancer, kidney disease, not to speak of many other associated diseases which are there. So, the resources available to us are very, very limited, and I am a little bit emboldened actually to make this discussion a little more frank by the newspaper report that I read in Times of India this morning that said that the government has actually looked at and inspected most healthcare facilities that are available in our country, and 80% of them are actually below par. So how do you think we should plan to cope this problem, or what can we do as a team together with the government to, solve this?
Thank you very much, and thank you for inviting me. I do agree with what you said. There is a paradigm shift in the challenges that we are facing as far as the health sector is concerned. Both the burden of disease is shifted from infectious diseases to non-communicable diseases, and therefore the challenges are different. Infectious diseases you treat a patient with malaria, dengue, and that's it. But non-communicable diseases is a treatment for lifelong, and you have to prevent end organ damage. So the whole strategy in terms of policymakers has to change from what was initially being done as, say, malaria eradication program or polio eradication program to non-communicable diseases, chronic disease management, and screening and early diagnosis. The other issue is that we are having a huge dichotomy that we have most of our patients in rural India where we have only about 25 to 30% of doctors. 70% of doctors are in urban areas where the population is in minority. So how do we change this? And then how do we move in providing more of preventive health rather than curative health? And I think there is therefore a need for policymakers, firstly, to invest more in healthcare. We need more investment. Currently, the investment in healthcare is less. Secondly, we need to see how can we look at technology to really bridge this gap between the urban and rural divide. How can we really reach out, whether it be telemedicine, telementoring. By telementoring, you can actually use ASHA workers and others, mentor them, and they can be your frontline workers. And that was possible in COVID, so I see no reason why it should not be possible when we start looking at it. But there has to be a change in our strategy, more investment, and trying to see how well we can reach out to rural India, where, like you said, healthcare facilities are below par.
See, as far as investment is concerned, the investment in healthcare was very, very low. This year, it has barely touched 2.5%, as the last, data that was published in the newspaper again just a few days ago. And healthcare is a state subject in our country. And there lies a lot of diversity and differences the way healthcare is delivered to the patient. For example, Delhi has a different model. The other states have different states. In South India, the models are completely different. So that's another issue that affects us, and we'll have to find some ways to sort of make a uniform policy for delivery of healthcare in different regions.
So many years ago, I was a member secretary of a committee formed by the 15th Planning Commission, the Finance Commission, to look at healthcare, and we had actually said that we should consider healthcare into the concurrent list rather than making it a state subject, because there is a huge diversity. You have states like Kerala where the healthcare system is doing very well, and then you have central India where you have a lot of, let's say, below par healthcare system. So one needs to understand why is this happening, why is there some states which are doing so well, and how can we look at that model, but try and fit it into a different area is not going to be that easy. So I think there is a need to look at healthcare and in terms of in the concurrent list as something which is more than just a state subject.
Let me now go to Dr. Abhijat Sheth. As you know, he is the director of the National Board of Examinations. Dr. Sheth, how do you think we can improve the quality of medical education? That is something, the government has been looking at, because the numbers are so large that the quest of the government to provide bulk number of healthcare providers, don't you think that we have lost somewhere on quality?
Yeah, thank you so much, sir, for inviting me. Let us take a broader view of this issue of the quality. We need, at the moment, the country need both the quantity as well as the quality. It always happens when you chase the numbers, the quality is likely to get diluted if you don't give a meticulous attention to the quality. Now, what is happening? Let us take two issues. The first issue is quantity, where we need numbers. But what happened in last 5 years, if you will see, the number of UG seats, undergraduate seats, have gone to more than 100,000, while number of postgraduate seats are still around 60,000, 60 to 70,000. And clinical jobs, clinical seats are around 40 to 50,000. Now, this ratio needs to be addressed. Many times there is a criticism that we have too many PG doctors, why we need to improve on this ratio, which is not true. Because every UG students must have a opportunity to do the postgraduate education. And once we will reach there, we will certainly able to address the quality issue in more effective manner. Our PG numbers are not high, but the distribution is skewed, and that is the main problem. In certain area, you won't find any physicians at all. In certain area, you will have a numbers of physicians. This is the one part. Now, this is about the quantity part. So, quantity part is not about absolute number, but we must try to focus on achieving the 1:1 goal of UG and PG ratio, which all the mature system or world is having this ratio. In fact, they have more PG than the UG students. This is number one. Now let us go on the quality part. What we need to do on a quality part? We had a great physicians gone to abroad all over the, we have exported so many great personalities. We have very strong, stalwart physicians within the country. Then why this is happening? The reason this is happening is this was a gold standard 3 decades ago, 2 or 3 decades ago, where we were dependent on our older type of system, where the education was only physical education, only within the hospital, only within the premises. Now what has happened? The complexity has increased, technology has advanced, education has become more difficult, uniformity is a problem. So ideally what we need to do is we need to develop a combined physical with digital model, where a physical part, we cannot ditch the physical part because it's absolutely essential. Simultaneously, we must enhance the skill-based education, which is very, very important in these days of a significant complex technology era of the medicine. Medicine is changing so rapidly. So we have to change with the medicine, the way the medicine advances. And we have to adapt the change, we have to learn to adapt the change quickly, which so far we were slow to do it. The next one is a digital education. The biggest advantage with the digital education is it brings the uniformity. It cannot replace the physical education, but certainly it complements the physical education. So phygital model is one of the most important model which we can adapt in our practices. We are trying at national board also the same model. Also, the 3I always consider is very important. Innovation in best practices. Then the next which comes is integration. There is a big criticism always around that we have a small numbers of institute, we have a low resources. But again, let us look at our system. We have two parallel systems, public healthcare system, private healthcare system. These two systems, if we can integrate it better for the education purpose, your quality problem will be addressed to a very large extent. And this is exactly in coming year we need to do. We understand behavior doesn't change overnight, but we must make a collective effort to bring the integration of these two systems. They cannot run in silo. And the last is implementation. We have to be very firm. While we are friendly, we have to very firm in implementing all the best practices. This is what all about the quality, sir.
You see, your points are well taken, but talking of the present, for example, because our need is the need of the present. We have so many medical colleges. There is no uniform standard in which education is delivered. There is a huge difference in the quality of the medical graduate coming out of different colleges. And we have different systems. There are some government colleges, there are some non-government colleges. Do you think there is a need for standardization of, the standards have to be put at par before we actually allow these medical colleges to be, becoming operational, or something has to be done to improve these standards, because we as clinicians have a lot of difficulty in getting very good quality medical graduates.
Yes, sir. It's absolutely important that we must come up with the new SOPs, new protocols of standardization of this medical education, both at UG and PG level. Let us take our own experience of the past. In the past, what was the most important was a meritorious process. What has happened recently? It's not about our country, it has happened everywhere. The money has come and money has started competing with the merits. And this is exactly where the system is getting more and more difficult to standardize. And this is something where it may be harder, but new SOPs and new methods and new policies should be implemented to ensure that more and more institutes becomes uniform and they can deliver the same level across the country at pan-India level.
I think even if you look at the NMC, they have all the regulatory things in place. The challenge is the implementation. How do we implement it in different parts of the country and in the public and the private sector?
I feel that mediocrity is prevailing over merit. That's a very big challenge for us. And the other thing is that we have a huge gap in terms of training the nurses and training the associate professionals, for example, technicians and other staff. And that is something that needs very, very urgent attention, both in terms of numbers, also the quality of colleges that give degrees to these nurses, and what they can actually perform with the patient. They have hardly touched patients, they get their degrees, they come and join hospitals, and we have seen many of them are not even capable of giving an intravascular injection. So how do we address that issue?
Sir, I think Dr. Abhijat has put many things forth. I think in this need that our country has of higher numbers of doctors, of nurses, of paramedics to be produced so as to meet our needs, now it seems that in a private medical college, a student who comes 12 lakh rank in the NEET exam can get admission, whereas a student who may be, at 60,000 will not be, and who cannot afford a private medical college may not get a seat. So that is something which I think at a policy level will need to be addressed. For the NEET PG exam last year, we all know that they brought the score down to 0. You get 0 in an entrance exam and you become a specialist in some. So I think at a policy level we need to look at it. Of course we need more numbers, but then in that quest for numbers, quality cannot be sacrificed. At least they have to be average. They cannot be below average.
So Harish, you made a point that we lowered the percentile for admission, but even then a number of seats in the postdoctoral programs actually went vacant. So how do you think we should address that issue? Because people are also at one time, on one hand, we have a huge deficit in terms of numbers of healthcare professionals that are available. Number two, we are accepting mediocrity or below average training levels, yet people are not taking the courses.
So the seats that fall vacant are usually in non-clinical subjects or subjects where students feel that it's too tough. You know, for example, now we have less number of people going for cardiothoracic surgery, pediatric surgery. Seats are going empty because they feel that this
Even
is
cardiology, the seats are going empty.
so we need to really look at how can we look at this speciality. And one thing that was done in some institutes was to offer a 6-year course that you do your MD and MCH or your DM in one go and you become specialist so that you can attract people from the very beginning. So there are various things that I think policymakers need to look at in terms of addressing the reluctance of students to really go into some courses. And that's why the seal fall vacant.
Sir, I will just add on to Professor Goleria's view. What is happening because we are already running this organization, National Board. What we have seen over last few years, and we are learning from our own shortcomings, that our process of accreditation has to be dynamic, and the number of seats which we are allocating every year should aligning with the requirement rather than it should be fixed. And that is one thing which both ourselves and NMC need to do it, that regular analysis, regular audit and requirement of the category of the postgraduate seats has to be recognized across the country, and we should increase and decrease at a certain period of time the accreditation of these seats, and this will be certainly very helpful.
Both Dr. Mahajan and Dr. Rana, I want to address this question to you because you belong to different fields. Both in terms of, just one moment, clinical medicine as well as in terms of imaging, for example. Now, we don't have a system of professional credentialing and giving privileges to people. There is complete freedom for anybody to start doing whatever he wants to do, or start reporting, or start doing whatever investigative facilities he wants to do, irrespective of a proper training, a proper credentialing, or a proper certification as to whether this particular person is actually certified to report or to perform certain procedures. So how we address that issue of giving privileges?
I think again it has to be at a policy level.
Yes.
And also some degree of policing that will need to be done. But in a country where quacks are free to practice, I'm told in Delhi there are more than 50,000 quacks who practice, and despite all the efforts of the Delhi Medical Association and all that, they continue to flourish. So how we will, why not a MD medicine person be able to treat a patient who has a heart attack in a place where no cardiologist is there? So even the fact that we have concentration of specialists in
Let's also welcome Dr. Kirat Salanki, medical practitioner and former member of Lok Sabha amongst us. Let's have a round of applause as we thank Sir for joining the panel discussion and requesting all of you all to take the discussions forward, please.
So, sir, 70%, 65% of India lives in the rural areas, and actually 65-70% of doctors are in the urban areas. So this discrepancy also that is there will have to be addressed, but you cannot expect a cardiologist to go to a tier 2, tier 3 town where there are no facilities, for his children to study in good schools. So this is a much, much larger issue. Hence, we have to look at separate models. We have to look at technology to be able to solve problems which are in our country. Telemedicine may be one area, and this is already in place. The government has the e-Sanjeevani. I'm sure over the years it will become more successful in the way it is implemented. The ICUs are already in place. So we have to think of newer ways and probably do out of hospital treatments more. In our country, everyone rushes to a hospital even for a small ailment. Even in All India Institute, they were forced to put a screening OPD so that only those people who actually need treatment in All India Institute should be admitted there. So I think we have to find solutions for ourselves, seeing our own problems.
See, Dr. Rana, internationally in many countries, this system of nurse practitioners exists. Now, do you think that is something which is possible in the near future in our country?
Actually, we have to address the problem of our country in our own way. We cannot copy anything from developed nations. And what we have been listening for the last 15-20 minutes, and we are all talking policy makers. I think the policies are in place right from the day of independence when we became independent. Every policy, and the policies are revised according to the time. But as Randeep told that, the problem of education. And why education is not done? Because it's the problem of money. Why GDP cannot be given by more than 2.5%? Because we don't have so much money to allocate to the health. We have to allocate funds to other infrastructure and everything. There are problems. Even in spite of that, we are achieving something. Major problem, as you are all feeling, that 70% doctors are in cities and 30% are in the rural population, while 70% population there. And Dr. Harsh just told that even in Delhi, the quacks are in thousands, while Delhi has got maximum doctors practicing now. So there we have to address that problem. Why quacks are thriving? Why you not question law? Even if you make law, after all, there is somebody somewhere required. There are not enough doctors actually. That is why quacks are thriving. Or there is no accessible to doctors. So those are various issues which are known to all of us.
This is precisely why I brought this issue up, that you create middle level health workers who are reasonably qualified and trained, but then you need to set in systems for them similar to what is the role of a nurse practitioner in the United States, for example. So that at least preliminarily they can help in follow-up of patients, they can, do small little jobs for them, and the burden on the major healthcare providers is reduced.
Yeah, that is what nurse practitioners are already in place actually, in major hospitals, and they are serving the role. And similarly, but you will be surprised that if you don't have any nurses, some adequate number of nurses in the primary centers and secondary. So we are talking something theory, But nurse practitioner is the answer. At least it's better answer than you can see that most of the nursing home in Delhi, they do not have MBBS doctor to work. We are talking of specialists, you don't have even MBBS doctor to work. And many small hospitals, they are employing, BMA, GMA, sending doctor, whosoever is there. So how many you will find, in my opinion, I will call them also quacks as far as those hospitals. Those hospitals are claiming that they are providing world-class services. But at the end of the day, night services, emergency services are being delivered by the people, those who are not qualified to do so. So we have to see the problem at large of our country. As you rightly pointed out, it's not a question of nurse physician only. Probably there was at one time, about 10 years back when we were MCI or 15 years back, there was a question of some, rural MBS or something like that. And we are talking of specialists, I say, right now to address the situation in our country, need of family physicians actually. And that is the most practical. If you are talking nurse physician, you require family physician also. Or if you are making this, I just want to ask Dr. Abhijat, if we made the seats of postgraduate seats as many as MBS, then are you contemplating that a primary center will be having a MD doctor, MS doctor, MS ENT, MSI, MS ortho, that is what is going to happen, Will that serve the purpose of the society, or will that serve the purpose of doctors? That is what I say. I heard yesterday also, we must increase to equal number. But I don't subscribe to that. You require family physicians at the level of rural population. And family physicians are required. That is what I say.
Into that, my personal thought is that we should produce good quality family physicians. Yeah. Absolutely, because the training that we people received at our MBBS time, we were able to do something for every disease. So that system is completely gone now. In internship, people hardly work. They are looking for hospitals or spots where they can sit down and read because they have to appear in the examination at the end of 1 year. So the result is that their, training in ancillary subjects or even in the major subjects, practical training is virtually quite low.
So if I may just add, there was a whole issue of creating family physicians. And there are courses on MD family physician which is started in certain colleges. But they had a problem that they were not able to get a job and they were actually just becoming like MD medicine. And therefore there is, I think, a need to really develop a cadre of family physicians, which is not only just doing MD medicine. They should know a little bit of obstetrics and gynae, they should know minor surgery, they should be able to do eye, ENT, they should be able to do some deliveries. That makes it a family physician.
This is precisely what we need.
Yes, and you need to then develop a job opportunity for them. So they should
be.
be.
Dr. Solanki, who is a former member of parliament and is also a practicing medical doctor, and I think he should give his input.
I would like to say something regarding this thing. First off, I congratulate Times Group and all the learned panelists and all my colleagues, professional colleagues here in this evening. Regarding the family physician, I did my MBBS and MS in 73 and 78. In those days, there were good family physicians. Almost family physicians were, majority of them were from medical allopathic MBBS doctors were practicing as a family physician. And they were very much helpful to the patients. They used to diagnose and accordingly they used to refer the patient. Nowadays, if you see the scenario, most of the MBBS doctors are either going for post-graduation and super specialty or they are going for abroad. So hardly MBBS doctors is practicing nowadays as a family physician. Most of the family physicians are from Ayush group of doctors. And I think there has to be a system of family physician. I think as a member of parliament, I of course at present I am an ex-member of parliament, but we should make a policy that the good family physician should be there. Otherwise what happens? Patient goes either to a oncologist, either to a cardiologist, and cardiologists always try to see the cardiology inside the patient. Family physician was seeing overall, and the position of family physician was wonderful. I think we should have a good family physician. There should be even MD also.
I think
we must change our medical curriculum. This country needs good quality family physicians. I have no doubt about it. And the training program in the MBBS level must be tuned or made in such a way that they are able to do small little procedures so that you can get the burden off the postgraduates all the time.
Dr. Sheth, today I feel that biggest need, we require medical manpower. But medical manpower cannot be created because of infrastructure. Infrastructure, there is no enough facility in the country, both in government and non-government. Right now, there is number one need to restore the value of medical teachers. You do not have now competent and dedicated medical teachers. We must restore the value of those so that people join medical teaching profession. And number two, no specialist can deliver the primary and even secondary service better than family physician. We should restore the value of family physician. Arandeep told that we have introduced course about 10 years back. National Board was the first to introduce it. And many people, they are serving some nice hospital and they do service, but they do not get jobs. So where somewhere government failed to do that, even at AIMS we have created family physician job, but enough candidates are not coming because they are not getting job now.
Dr. Rana, what you're speaking is at postgraduate level. Once they finish their MBBS, they do a DNB in family medicine or a postgraduate training. What I am saying is that we produce good quality undergraduates who are well versed with these small, little procedures.
Let me explain. That was a system of this thing about 40 years back when we were doing post-graduation.
Exactly.
You don't require degree or so. This degree came only because people were going for post-graduation. Otherwise, at that time system was that people will do MBBS, they will go to rural center, or they will be posted at district hospital. Within 7 or 8 years, people and with MBS degree or even GMS, they used to be fantastic surgeon. They were doing all sort of jobs, They were not able to do, of course, they will not do coronary angiography or something like that, but they could do all basic surgery at the level of district hospital. Today, neither they are allowed nor they are able to do because there is no enough training in the MBBS actually.
So, sir, two things in that. One is the reason why this is happening is that if you look at an MBBS student, he is more worried about cracking the exam, mugging up MCQs rather than going to the ward and looking at clinical medicine, examining the abdomen, picking up hepatosplenomegaly. He would like to know all the causes of hepatosplenomegaly because that's important for him to clear the exam. So we need to really look at our examination policy in terms of are we really looking at the right thing in terms of assessing candidates rather than just mugging up. That is one, sir.
This is happening because of non-pragmatic approach of government to health, sort of health problem.
So
because they are not thinking, we should have not allowed when, and then there is protest on doctors' fraternity. When this was a proposal that at least no MBS doctor should be allowed to join MD or MS till they have served, even in the medical college, because they are not, today MBS graduate who comes from the medical college, what to write prescription, they can't give injection, they cannot do anything, they don't know anything. And their worry is that they are least bothered that they are going to provide service anywhere. They all want to do their eyes on PG actually. So there is a wrong step actually.
So that is one.
Cost of is because of that only.
The other issues, as you rightly said, there is no incentive for teaching now. We are losing good teachers. We had gurus where we would look up to them and they would be our mentors. Today, the society has changed in such a manner that our values have changed and the values of teaching have come down dramatically. Unless we incentivize teaching, we have now worked from education which was more in schools and colleges to coaching classes.
The government
So everything has changed
dramatically. It's not happening now.
So this
Sir,
is what,
in
fact, my last point.
If I may just come in, sir. On this, the government had proposed a common exit exam for MBBS students, which would be done after the final year. When we passed out, we had internship where we actually went through we were made to do surgeries, we treated the heart attacks and all that. 12 months, we went through every department. Now actually these students are just mugging up during that time. They want to crack the exam, as Randeep has said. So this common exit exam, which was proposed and which would be very, very beneficial, actually there were a lot of protests against it because there is a non-uniformity of teaching. But that could be one solution. During our time, we used to also do a house job. One in surgery, one in medicine for 6 months each. And then we would go for specialization. So if someone didn't become a specialist, at least he was good enough to go into community and do some basic surgery and medical treatment.
See,
I think maybe the time has come to relook at that.
See, everyone is an aspirant but does not get into a postgraduate seat. So you have to create that system again where better quality graduate training is given. Just quickly, the last 2 points were that, of course, we are awfully short of infrastructure and we don't have anybody representing the government from where we can really ask for comments. But from Dr. Guleria, I like to ask that we need to strengthen our universities. So that is something that we have to consider very, very significantly. The quality of teachers, the way the teachers are selected, the so to say, emoluments that we give them, and what are the other benefits that we can give to good quality medical teachers. We need to go back to the drawing board to draw all these things again.
So 2 or 3 things. So one is we need to develop an incentive-based system so that teachers have the incentive to teach. We need to also understand that medicine has changed dramatically. We have moved from an era of clinical medicine to investigative medicine. And with investigative medicine, there are its own challenges, whether it's the cost, whether it's how you do treatment. You would spend 1 hour examining a neurology case and looking at the plantar, whether it's upgoing or downgoing. Now you get an MRI done. So we have to accept that those changes have happened. And therefore, I feel that we need to find a mixture of the two. We can't have a person in rural India saying, I can't diagnose a stroke because I need an MRI. We have to be able to do that. I have people telling me I can't diagnose pleural effusion unless I do an ultrasound. We used to just see for a dull percussion note and put a needle in without even thinking about it. So I think we need to understand that we need to sort of, how do we amalgamate the two things? And that is the most important thing. So teaching, looking how technology has come in, how investigative medicine has come in, and how the curriculum can be changed, bring back the teachers, and then invest in education so that medical education becomes like what it was in the past. Doctors from India were the ones which were highly rated. So we need to see how do we bring that in with changing times and the changing paradigm.
My last point is regarding research. You see, the postgraduates who join, they must be taught research methodologies for producing credible results. That is one. And secondly, we should do India-specific research. What are our problems? How can we provide treatment at lesser cost? Why can't we do good quality local manufacturing? And then, use those things in the stent companies, for example. The stent industry has already proven that point. And the same thing can be, carried to other specialties as well. So we should encourage our own local manufacturing. That will bring the cost of the healthcare down significantly. And this is what I think we should be doing. The research should be India specific, our own issues, how we try to deal with them, not necessarily copying the Western methods or Western styles of giving treatment, but innovate our own methodologies.
Definitely. I think we need to really look at a strategy why doctors can't be entrepreneurs. Why can't they have their own startups, and how can we not facilitate them and do that in an India specific manner? I think Harsh is sitting here. He is one of those who has really a lot of knowledge on this in terms of entrepreneurship.
Just very quick, 30
Sir, I would
seconds,
say,
we are up with time.
In this era of evidence-based medicine, there was an era when one would feel the pulse, palpate the abdomen, give medicine, and the patient would accept. Which patient today is going to accept? Even if they accept, and we are not gods, we will be wrong, then he will take you to court. So that also, these legal issues, the loss of faith, the materialistic world. I mean, doctors are not different from society. So all of these, yet, if we look at even the corporate hospitals in this country, we deliver the cheapest healthcare in the world, sir. We are cheaper than healthcare delivered in Pakistan, Bangladesh, Sri Lanka and Nepal. So there is a limit when technology is there, when there is aspiration for the doctor also to have a good quality of life. It is going to cost money. We are the cheapest, yes. The problem is affordability. And that's where I think schemes have to come in. Insurance schemes which actually leave viability in the healthcare delivery system also. They should not be such one-sided that the charges given are so low that the hospitals are going to close. So it's a complex issue. I don't think we can solve it sitting here.
Point very well said and very well taken. And with this, I think the time is up. So we've had some fruitful discussion, although a lot of gaps have still been left in this discussion because this is something that we can't finish in 30 minutes. But I'd like to thank all the panelists who have joined with us today for sharing their views and being a little frank in their approach. And let's carry this forward together. Thank you very much, ladies and gentlemen.
Thank you so very much.